ask Alice, the question you raised, was raised about responsibility, about change in the record, and the GP saying, "Will we be held responsible for that?" And that wasn't the case. Or they were reassured it wasn't. They weren't going to be held responsible apart from safety issues. How did you overcome when there were issues? For instance, let's say your citizen sees that, oh, well, that's not right, or that there's a problem there, or there's an error being discovered. What was the mechanism for that to be reconciled? Did it go back to the prescriber, or I'm just interested to see how you sorted that out?
Yeah, thank you for that question. The problem was that you have to mark FMK reviewed when you are doing something, when you are changing something, and the doctors, the GPs were afraid if they mark FMK reviewed, they were responsible for all ordinations, but they were only responsible for their own ordinations, and of course responsible for finding obvious mistakes. So if something was changed, if something is changed in FMK, you can always see the name of the doctor who have been changing it, and then you can of course call or write him or her to find out, why did you change my order. But about the responsibility, that is mostly this mark reviewed issue that was the problem.
Thank you. My name is Janne. I'm coming from the Czech Republic, where I am working as an external consultant for the Ministry of Health in the eHealth space. And first of all, I would like to thank you all presenters for the excellent overview of their systems. And I have two questions. The first one is technical to all the speakers. And I would like to know if they are using any standards-based implementation for the transmission of the information from the origin to the either central repositories or distributed ones. And if they are using international standards, which standard is it? And the second question is to Luke, Nicolas, who was asking my question regarding the business rules on the prescription system, and if he could a little bit elaborate more on the Finnish scripts, which I can read from his answer. Thank you very much.
This thing about international standards, we have been on a quite funny journey in Denmark, because when we started out back in the 90s, we started out with international standards using a UN EDIFACT for our data exchange. Then suddenly in the zeros in the beginning of this century, a national initiative, not only covering the healthcare sector but the public sector in Denmark as such. A national initiative was launched for the public sector to use a common XML based standards, and we were told to move to this national standard. And as you might recall from my presentation, the common medication record was actually launched in way back in the beginning of the century. So actually today, to make a long story short, the shared medication record in Denmark is based on national XML standards. We are trying very hard in MedCom to move from EDIFACT and this national XML standards to EHTEL 7 FHIR. So we are in the middle of that transition right now. I think that it will take several years before we will see the shared medication record system being changed. And I think Alice told you why.
on my side, I think, as I tried to show, what we tried in Belgium to deal with the question of standards as much as possible in the central reference database, which is being used by all the users. So we are providing quite a number of identifiers, and we are one of the countries, for example, where we went quite far in the clustering of drugs, where, for example, prescribing, it is now very much possible for all the client system to prescribe not on specific drugs, but on a cluster of drugs. And that has been possible because all the work has been done in the central database itself. So, and as I answered to INEC, we plan to go further. It's a discussion with the industry, obviously, because they want to keep a bit their comparative advantage. For example, for the drug-drug interaction, for the time being, that's what makes a bit the difference between the products. But there is a strong willingness to include in the system, for example, from the healthcare provider, the request is that we provide it also from the central database in the future. Now, if we look at the standards themselves, as we said, we have a federated system. So we have been building a number of web services which are used and reused for all the data sharing in all the different applications. And we try to have an ecosystem where everybody works with the same. And when there is new request, we develop them. That's for data exchange. And as Lars has just mentioned, we have the same issue with FHIR because we want to to open up to the patient, to new developers, and so on and so forth. So yes, FHIR needs to be taken on board. And as Lars has mentioned, we are all learning for the time being. So we will have, by the way, in June, Janne, I think the right time to mention it, a specific webinar, webinar on how we deal with that and how we can co-work with the industry in June. So stay tuned and for that one. But yes, we have all the identifiers that we need for the system to be interoperable in Belgium and to support quite a number of use cases, I would say, but not yet at the European level. And that's also possibly the subject of a future webinar, I think, where actually there are big efforts being done at European level now in order to have a wide implementation of the IDMP standard, and also to have clear terminological choices. Well, not necessarily one, but a number of semantic choices, clear choices being made, in order to be able to go beyond silos, both at geographical and use case level, and deal with the new challenge of artificial intelligence and wide big data elements. So it's coming up also, but it's parallel to FHIR, and I guess it's going to take probably the same time again, a few years' time. But there are big progress. I mean, we have in one project, the project Unicom, for example, there are 11 agencies who are already implementing this standard in the re-engineering their database, the national database, to comply with this standard. For your second question, Inek, the script I was mentioning are the duodecim scripts, which are interesting because they are made to be implemented by EHR directly. So what we've done in Belgium is that we bought the license for all the EHR producers operational in Belgium. So it's not a cost for them. We just bought it, and we just made the few adaptations needed in order for them to be, well, the few. There were quite a number of things to be done in order to be available in French and Dutch, and they are now used by most of the GP systems.
Thank you.
Thank you very much, both. I think there is a question from Mark. Please.
Yes, thank you, Janne. Good afternoon, everybody. With the two examples of Belgium and Denmark, we have, in fact, very much different strategies in terms of developing, implementing, and deploying this single medication record. Where, and of course, because of different reasons, but where Denmark is really has started from with a central system. Where everything is integrated, while in Belgium there are a number of different systems which are working, which were developed independently and that are being orchestrated now with the VDIS project. So thinking about the new, those countries and regions who are in the beginning of the journey, what kind of recommendation or how to address this question on starting with with a central system or starting with in developing different modules and then integrating them in a later stage.
I will
Janne,
answer if you allow me, Janne, because I think it's an anecdote. But actually, when in 2015, when we discussed well, even before in 2013, so Denmark has already this vision very clear, and was already saying to anybody who would be happy to hear it, please take into consideration that the future is this, not independent e-prescription system. So if you have not started yet, start immediately from from this perspective, although it might take a bit more time to develop it because it's complex, but work on these requirements. And when I said that to my Belgian colleagues, they didn't laugh at me, but they say, well, you're dreaming. You're just dreaming, and no, the people want to have it quick, and so we'll do it. I didn't succeed to convince them, Mark. So basically,
oh gosh,
that's as simple as that. So for me, clearly, the way that Denmark is, this gives, by definition, an incredible number of possibilities. What we're doing in Belgium, basically, I think we'll end up with a similar situation that you take a bit more time to go in very advanced functionalities. That's my perception, at least.
Mm-hmm.
Well, I think the most important thing is to take into account what is the current situation, what is your starting point. I think that it would probably with this very decentralized healthcare system in Denmark, it would probably not have been possible to introduce a central solution if we were started out earlier. But somehow we were standing on the shoulders on this strong tradition starting out way back in the 90s, and that's one thing. Another thing is that we had the GPs and the GPs Association as a strong voice. And one thing about the GPs is that they are IT vendors. They operate all over the country. So even though there's I think today we have 7 different IT vendors to the GPs in Denmark, they operate they operate in the whole country. So it would be it's very obvious in that situation to think, okay, we need a central. If we need to start this out, we need a central node for this, because otherwise the same vendor would have to integrate locally with several local installations, and they would never do that. It's too expensive and hard to handle, hard to manage for them. So again, the GPs and the IT vendors, for them, I think it was obvious to have a central solution in Denmark, but only because we have the history that we do have for integrated care.
Okay, I think it's a quick question. Since we are talking about central in a way, Belgium and Denmark, what are your plans concerning accessing the MyHealth EDU system? So one can read that Belgium receives funding from CEF to get the access, but Denmark doesn't. So what are your plans and wishes? Now the question would go particularly for Denmark, since you say your system is not compatible at all.
Well, I don't think it's it's not a secret that Denmark's not been very active when we're talking about the cross-border services, but it looks like that's changing, Stefan, and hopefully we'll be getting into that game very shortly. So I think that's the politically correct answer for the time being on that question.
Okay, thank you.
Actually, that's been a bit the same than in Denmark. It has been very difficult to have the European dimension included in the eHealth roadmap. It has been included in 2019, finally, and mainly due to the pressure of the Brussels region, which is truly international. Now, how this will, the system is sufficiently flexible, as you can see, today to actually make it fully compatible. So now they are working actively for the patient summary and the Belgium e-prescription system to be part of it. And we should be operational, so they say in 2023, but we'll see.
Okay, thanks a lot.
No, I was just as a final question, or I was curious because I think, Sam, on one of your slides, you had sort of a list of goals. You can say that you were hoping a single solution could kind of come. Did you find, did the two presentations reassure you in a sense in that it was possible to achieve the ambitions you have?
I think that, yes, I think that the two different ways of approaching this, there are parallels across so many different areas of what we're doing. And that cross-boundary question still applies in the UK because the Scotland and England has a slightly different system, and we need to be able to do that cross-boundary aspect. I think I'm reassured that our understanding that the complexity and difficulty is there. It's been done. And that some of the things that we've perceived early on as being challenges have been echoed in the presentations that we've heard today. So it feels like we're in the right direction. I think what we are having to do is to be clear about what we're trying to achieve and what the solution, this will deliver, in order to manage that expectation and to really ensure that in the investment, which is a lot of money and time and effort to do this, is understood that target future is what we are going to go for. And I feel a lot more reassured, and will be coming back to some of the speakers to individually to ask for advice about that we are in the right direction. That's what I've taken from today, and that there's lots to be learned, and hopefully share and reciprocation when we move forward. We're planning on doing the things we've just spoken about. We're planning on using HL7 FHIR standards and such like, and to use public cloud. So hopefully we can come back and share once we've developed.
Thank you very much for taking the time to join us today.